if you look at so good afternoon and welcome. This is the last and final Lunch and Learn, part of our IAWH SMVP Hypertension Control Program, and I'm so happy that you're here. I hope everyone is doing well this season and doing well today. Since January, as you know, we had 2 cohorts. This is the 2nd cohort, but every last presenter that we've had has talked about the importance of sleep and what that means to our health. The doctors, the nurses, those who have had cardiovascular events have all talked about how important sleep became in their lives, or how important sleep is. So yes, when you're sleepy, when you're sleep deprived, you get irritable. You may like fall asleep while you're watching television. You may just not perform your best. But there are much more serious consequences for sleep deprivation and just not getting the proper amount or quality of sleep. And so our speaker today is going to talk to us about that today. And I'm really looking forward to this. So today we are joined by Dr. Zara. I've been practicing this. Dr. Zara let me
you
try
could do it, Martirosyan.
it.
You just phonetically spelled. I know it's a long one.
Martirosyan.
There you go. You got it.
I've been practicing. Martirosyan. Okay.
There you go.
She is assistant professor at Howard University College of Medicine, and is also at the Howard University Hospital Sleep Disorders Center. She's going to talk with us so that we can understand the vital importance of sleep in our lives. Dr. Martirosyan has been a physician in practice for over 10 years. She received her medical degree from Ross University School of Medicine, and she completed her residency at Inglewood Hospital Medical Center, Mount Sinai program in Inglewood, New Jersey. She completed her sleep medicine fellowship at Baylor College of Medicine in Houston, Texas. Welcome, Dr. Martirosyan.
Thank you so much for allowing me the opportunity to talk to you guys about this topic that is very dear to my heart and should be dear to everybody's heart, the way it's affecting our daily living. So thank you again for allowing me to talk to you guys, and I would like to share the screen, and you guys tell me if you can see my screen, okay? Let's see, share screen. All right, so let's see. Can you see my screen?
Yes.
All right, and let's see if I could make it in a presenter mode. Okay. So
Sure.
Sleep and health. I was told that you guys are interested in basically learning about how sleep is affecting our health. And unfortunately, sleep is the most kind of underappreciated aspect of our lives that is in our society, unfortunately, is first one to go whenever we're pressed for time. We always tend to sacrifice sleep, in order to complete tasks or do whatever, and that's probably a very wrong approach in terms of overall health. So what is sleep, right? Sleep is an essential, biologically motivated, very complex behavior. It is by no means a passive slumber. It's a very, very active process. And during sleep, lots of things are happening in order to prepare us to function the next day. It clears the body of the toxins. It restores the nervous system, restores all the organs and the cognitive function. Okay, we in general as adults, by we I mean adults 18 and over, usually require anywhere between 7 to 9 hours of sleep per night to function properly, to have normal motor skills and cognitive function unimpaired during the day. Again, not everybody is a robot and has to sleep exactly 8 hours, but majority of people fall into this category of requiring at least minimum of 7 hours of sleep. Sleep is required for survival. and the drive for sleep is very strong and very intense. And that's why we may have noticed, like, if we deprive ourselves of sleep for whatever reason, we for prolonged time, we feel that we can no longer remain wakefulness. We can actually fall asleep despite not wanting to inadvertently. And it's a preserved, evolutionary preserved function, because it is so important for survival. In the very early stages, when people were doing experiments on animals and depriving them from sleep, rats or mice, they would wake them up soon after they would fall asleep. That's, having, days of basically no sleep. After a few days, the animal would die. So that's when it, kind of doomed on us. Okay, this is an important and necessary part of our function in order to survive. So what is important is not only the quantity but also quality of sleep, right, in order to feel good and basically maintain daily function. So research has shown that insufficient sleep associated with adverse health outcomes. There are many adverse outcomes that have been associated with sleeping less than 7 hours a day, be that heart disease, be that compromised immunity, even cancers has been linked to sleeping less than 7 hours of sleep. So another aspect of sleep is the quality. So you may allow yourself to sleep 7, 8, 9 hours, but is your sleep quality decent enough? And that is the key question, because you may sleep normal amount of hours, but may wake up feeling not restored, not refreshed, and felt like, okay, maybe I didn't feel enough, or didn't sleep enough, or didn't sleep well enough. And what happens during sleep, normal sleep, we go through stages of sleep, which is called normal sleep architecture. And certain disease processes tend to interrupt that normal architecture. And that's also causing basically disturbed sleep and causing further deterioration in our health. So what are the normal stages of sleep? So this slide that I wanted to show you guys is basically called hypnogram. It's basically a fancy word of, describing sleep stages, normal sleep stages that we all go through, starting from, when we're awake, we go into light N1, we call it N1 stage sleep, where we spend about 5 to 10% of total sleep duration. Then we progress into deeper night of sleep called stage 2 sleep, where we spend about 50 to 60% of sleep duration. And then we go into REM sleep, which is, it stands for rapid eye movement sleep. That's when we dream, the vivid dreams, all that we remember when we wake up, it happens in REM sleep. Okay, and stage 3 sleep, which is basically the deepest sleep and a very important part of sleep. We spend about 15 to 20% in it. Sleep consolidation, the memory reinforcement and knowledge consolidation all happens during sleep and the stages of sleep. So it's very important to have this, architecture preserved, and we kind of cycle through it as we sleep, right? So what happens in abnormal disease state is this shows you is a normal architecture. The bottom slide is look at all these hashtags. These are arousals, okay? Whether patient is aware of it or not, or that he or she is waking up, happening. Look at the stages of sleep, totally disturbed. A very large proportion spent in a very light sleep. So that's not a very restorative sleep, and a great reduction in deeper stages of sleep than 2, 3, and REM, basically nothing. So this patient will definitely suffer during the day, okay, because very disturbed sleep architecture. So the risk of if you sleep less than 7 hours, or if your sleep is disturbed. Heart disease is number 1. Strokes are very common. High blood pressure, diabetes, weight gain, and obesity goes hand in hand with that. increased risk of death, sudden cardiac as well. And as I mentioned, impaired immune system and depression and anxiety. Just think about it when you get a bad night's sleep or didn't get enough sleep. You wake up not feeling so great, right? You don't wake up in the best of the moods, right? And that's kind of vicious cycle. It feeds on itself. The anxiety and depression make us sleep worse, and not controlling, not improving our sleep makes the depression and anxiety worse. Let's see. So that's another thing. What other things can happen when our sleep is compromised, right? Well, impaired performance at school or work. We're just not doing our best. The increased risk of errors and accidents. Motor vehicle accidents have been increased, not only due to drowsy driving, but also due to reaction time decrease, because reaction time is not the same when you don't sleep or your quality is less. And falls, right? So accidents definitely happen. We as a society in United States spend about $150 billion in losses due to undiagnosed sleep disorders, right, that impair our sleep. And that's basically a sum of workplace accidents, motor vehicle accidents, loss of productivity, whether it's absenteeism from work, like calling in sick because you're not feeling well, you feel tired, or because of comorbid diseases that lands us either in a hospital or in the doctor's office, okay? So it's a huge economic as well as medical issue in our society. So as I said, quality, many disorders can adversely affect our sleep. Just a few examples that I can think of is sleep apnea is one of them, insomnia, mood disorders, chronic pain can wake us up, right? Menopause, all these hot flushes that women go through, surges, all this will definitely impair quality of our sleep. And as I mentioned earlier, though most people do require 7 to 9 hours of sleep, some may need less or some may need longer sleep. And those are called long sleepers and short sleepers. It's genetically determined. There is a specific gene that kind of codes for sleeping less and functioning very well. So the short sleepers would be somebody who has been he or she has been functioning perfectly without any comorbidities, no adverse health effects, and no adverse, subjective functioning, okay? That's called a short sleeper. Now, long sleeper is the same thing, somebody who needs every day to sleep 9.5 hours in order to be fully functional and healthy. And that's okay. If that has been going on all your life, that's fine. But if something's changed and you feel like, oh, now you require more sleep, then that's a problem. So how do you know if you're at risk of having an impaired sleep? Let's say you're allowing yourself adequate amount of sleep, but how do you know if you're at risk of having a sleep disorder? Well, it's pretty easy. We usually ask 8 questions. And if the question to any of these 8 questions, if 2 or more questions answered yes, then you're at higher risk and you need to be evaluated. So what are the questions? Here they are. Are you overweight? By overweight, we mean BMI 30 and above, so actually it's obesity. Are you on blood pressure medications, or have you been diagnosed with high blood pressure and being treated with lifestyle choices? Do others tell you that you snore? Because a lot of people, if you ask them, do you snore? If they sleep alone, they will say, I don't know, I don't think so, because they don't hear themselves snore. So you always ask, did anybody, family, friends who stayed over told you you snore? So that's another risk factor. Are you age over 50? Do you feel sleepy or tired when you wake up? Or do you take naps during the day, even though you slept all night? Do you stop breathing or gasp for air at night or choke at night? Is your neck circumference 16 inches or longer? And some people don't know their neck circumference. So then I ask them what size shirts they wear, the collar size, especially for men who wear shirts. And are you a male? So males are more at risk of having sleep disorders. So if any of these answers basically are yes, and more than 2 are yes, then you're at higher risk of having sleep disorder and you need to be evaluated. Okay. So what is obstructive sleep apnea that I've been kind of referring to? It's a very common and very serious disorder that is also kind of underdiagnosed in most populations, especially in African Americans. It affects our airway when we fall asleep by blocking it or by narrowing it. So when we fall asleep, right now our airway is patent and open, right? But when the brain falls asleep, what happens to the airway? It kind of can get blocked by extra tissue or by just relaxing of the musculature around it, or get narrows, okay? That's limiting the air entry into our body. Sometimes we may, some people will have some symptoms from sleep apnea, whatever they may be. But others, about 50% of people with significant to severe sleep apnea will not have any symptoms. So it's very important not only to screen them for symptoms of sleep apnea, but also to refer them to sleep physician if they have any comorbid conditions of sleep apnea. Comorbid conditions of sleep apnea, which I'll mention on next slides, are basically any heart disease, high blood pressure, irregular heart rate, heart failure, strokes are all considered comorbid conditions of sleep apnea. Okay, sometimes you will hear snoring from a patient when the patient is asleep, and that's basically a struggle of air creating turbulence trying to get into kind of closed hole. And irregular breathing may be reported by bed partners saying, okay, sometimes patient takes a pause in respiration and then the big gasp of air. Or even patient may themselves say, like, sometimes I wake up gasping for air like this. That's also a sign of sleep apnea. Blood oxygen level obviously drops, right? You're not breathing as well, so the oxygen drops, causing frequent arousals of the brain, releasing chemicals to kind of arouse the brain to restore the normal breathing. Because remember, we breathe normally when our brain is awake, and we do not, excuse me, please. And we have the problem when the brain falls asleep, right? So frequent arousals with trips to the restrooms. That's another thing that some people will say, oh, I go to the restroom like a few times a night. Okay, so that's another thing that, you know, causes the problem. So this is a slide that I basically wanted to show. This is normal airway on the left, right? As you can see, this is the patient is upright and the airway is not compromised. Everything is open. Now look at this patient. He's a little bit overweight, as you can see by the extra tissue under the chin. The tongue fallen back, right? He's sleeping. Soft palate kind of falling back, epiglottis. So more than one place where the airway is compromised, okay, and narrowed. So this is basically the mechanism of narrowing the sleep apnea. It's very, very common. It's more common in men than in women, about 25% versus 10% in women. But that being said, after we hit menopause, we kind of tend to catch up to men, unfortunately, like in other conditions. So what are the risk factors? Obesity, race. By race, I mean African Americans and Asian populations tend to have a more obstructive sleep apnea compared to Caucasians. Age, as we age, we're more at risk of having sleep apnea. And like, if you know, that's why on the previous slide, I said age greater than 50. Nasal obstruction, if you have any kind of extra tissue in your nose, like whether that's a polyp or deviated septum or some extra tissue in your sinuses or nose, can predispose to having sleep apnea. And obviously genetic predisposition. So families who have sleep apnea in their first degree relatives are more at risk of having sleep apnea themselves. We had an exponential increase in sleep apnea in United States due to exponential increase in obesity after, you know, our basically food choices have changed in like late 80s and 90s. All this processed food that we were consuming that not doing any good to us caused exponential increase in obesity, and obesity goes hand in hand with obstructive sleep apnea. And we know that there's a high incidence of obstructive sleep apnea in patients with cardiovascular disease. So this is that on the top, you see the normal individual sleeping, the solid gray line or uninterrupted sleep, right? And this patient, look at, there is no solid gray line. Look at all these hashtags, the light gray, these are basically arousal from sleep. So you could tell that this patient's going to wake up feeling maybe okay initially, but towards half the day, they're going to feel tired. They're going to feel like, oh my God, I can't go on. I got to take a nap. And that's what happens when the sleep is fragmented and interrupted. A lot of people feel the need to take a nap, whether that's a half an hour, or 2-hour nap, but they tend to take naps as well. So how does obstructive sleep apnea make you feel, right? Well, you could wake up feeling tired and unrefreshed, even though you had, 8-9 hours of sleep. You may feel fatigued and irritable all day. You may have difficulty concentrating at work or whatever you're doing, learning something, or you may even unintentionally fall asleep. When the sleep drive is so much. And those feelings result from your body being woken up numerous times at night, whether you're aware of it or not. So those arousals to restore the respiration at night may not be perceived by the patient. It may not be total full arousal like you and I are wide awake right now and talking. It could be just subconscious arousal of the brain enough to restore the respiration. So the patient may not feel that, oh, I was awake half the night, but it's still enough to disturb the daily function. Okay, and that's why we feel that way, because the brain is not kind of getting the rest it needs. So because this talk is primarily focused on cardiovascular disease, I wanted to show you how the sleep apnea actually affects our heart directly, right, and our blood pressure. So this is a person who has compromised airway during sleep, narrowing air entry, right? What happens? Oxygen goes down in the blood, right? That creates a panic in the body. So lots of chemicals, stress chemicals being released to wake up the brain and say, hey, wake up and restore normal breathing because I don't want to die. My oxygen is dropping. So then the brain has to wake up and restore the normal breathing. During that time, while the body is trying to suck in air through either closed or very narrow opening, what happens? You have to generate negative pressure to suck in air, like to inhale. Even now, right, when we inhale, like it has to have some pressure to suck in air, right? So at night, when that compromise is happening, you have to generate so much more negative pressure to suck in an air. Almost imagine like breathing through a straw. Okay, it's very difficult. So all that negative pressure that's generating inside your thorax, between your neck and your abdomen, pulling and tagging all the organs inside it, okay, like stretching the tissues and tagging, and that creates a very dangerous state of affairs because there's inflammation increases, there is the chemicals, the stress chemicals are increased from the nervous system, and that pulling and tagging distorts the anatomy of our heart, causing us to have heart failure, causing us to have high blood pressure because of all those chemicals, and stiffening of the tubes, that basically the vasculature, causing us to have very high blood pressure. And heart attack and strokes are frequently happening because of the small blood clots are forming due to obstructive sleep apnea as well. And that's why we see sudden cardiac death during night frequently. That we learn that our patient went to sleep and never woke up. That's called sudden cardiac death and most likely linked to sleep apnea. All right, so it's directly related to heart disease and many like other conditions, but because this group is primarily concerned about heart disease, that's where I will stop. So we know that sleep apnea, and by the way, whenever you see OSA, it's basically a short form of saying obstructive sleep apnea, okay? Obstructive sleep apnea is linked to heart disease. We know that 50% of patients will have obstructive with high blood pressure will have obstructive sleep apnea. We know that about 30% of patients who had heart attack will have sleep apnea. About 25% of heart failure patients will have sleep apnea, and about 60 to 80% of stroke patients. Okay. So this study I took it from my resident talk, so it's more medical, but this slide is just to show you, look at the slide only. So this is a Wisconsin sleep cohort study, which looked at over 6,000 people. And they compared how many of them had sleep apnea. So sleep apnea, basically, this is mild sleep apnea, the yellow bar, and this is moderate sleep apnea, the green bar. So having sleep apnea, so have somebody who has no sleep apnea, the risk of having high blood pressure is 1, okay, almost nothing. Having mild sleep apnea, the risk of high blood pressure increases to 2.2, or twice that, okay? And having moderate sleep apnea, risk is tripled, okay? So this just tells you how directly sleep apnea relates to blood pressure. And again, implications of untreated sleep apnea are vast. Just today talking about heart disease and blood pressure, but it affects everything. It affects diabetes, metabolic dysregulations, obesity, job impairments, arrhythmias, headaches, and mood disorders, everything basically, because we all rely on proper respiration and proper oxygenation during the night. So when should I get evaluated, right? Sleep medicine evaluation. Well, if you experience any of this, okay, if you experience loud snoring, either you hear yourself or somebody else tells you you snore, if you choke or gasp for air at night, if somebody tells you you have pauses in your breathing at night, if you wake up with a morning headache or dry mouth or dry irritated throat, if you have excessive daytime sleepiness despite sleeping adequate amount of time at night, if you have insomnia, and insomnia by that I mean not so much difficulty falling asleep initially, but actually falling asleep okay, but waking up during the night frequently, that's more of a sign of sleep apnea. Waking up with a dry mouth, I already said, frequent needs to urinate during the night, trouble concentrating during the day, trouble with memory or learning new things, moodiness and irritability or depression. So any of these symptoms should warrant evaluation by a sleep practitioner. So remember how I said that some people are without symptoms. So how do you know if they are at risk? So these are the conditions that we call comorbid sleep apnea conditions that also should warrant a sleep apnea evaluation. These are obesity, high blood pressure, arrhythmia, which is irregular heart rate, heart failure, stroke, diabetes, mood disorder, whether it's depression, bipolar, or anxiety, insomnia, cognitive or memory impairment, and attention deficiency disorders. All these disorders should trigger a primary care physician, general physician to refer a patient to a sleep provider. So now that you know how important it is, how do you improve your health? How do you improve your sleep, right? Well, make sleep a priority. It can't go like if you have a deadline or if you have something to do, you cannot compromise your sleep because you know the downsides of it. You have to make it priority. It's not a disposable part of the part of life. It's essential for survival. Avoid common sleep disruptors, right? What are the disruptors? Are alcohol. Contrary to the common belief that some people say, "Oh, I take alcohol to kind of help me sleep." No, it is a very potent sleep disruptor. It may make you drowsy initially, but then as soon as it hits the liver and gets metabolized, it produces metabolites that are very arousing, okay? So people actually frequently wake up when they consume alcohol. Caffeine, whether that's coffee or tea or sodas, right, is very disturbing to sleep. Tobacco products. So sleep at least 7 hours each night and have a very regular sleep schedule. So healthy sleep requires good quality and regularity. You have to be regular, almost like military, okay? Set up your bedtime and wake up time and try to stick with it, because we all as people, as even animals, have circadian rhythm, which is what it is. It's our biological clock, right? When we sleep and when we're awake. So having erratic sleep schedule, going to sleep one day 9 p.m., another day midnight, is messing up with our natural clock, and it's very hard for us to kind of sink into that normal healthy pattern. So that's why I say always have a bedtime routine to kind of in the evening unwind, stop what you're doing, unwind, and then it doesn't have to be prolonged. It could be even like half an hour, like dim lights, and prepare your body to kind of go to sleep, and have a set time, whatever time works for you, whether it's 10 o'clock, 9 o'clock, 11 o'clock, midnight, it doesn't matter. Whatever time agrees with your body, you set that time and stick with it. And preferably stick with it even on the weekends. And it's okay, we all kind of go to sleep a little later on the weekend, and because we have an option of sleeping in if we don't work, right? But try to not vary it too much. Half an hour is okay, but more than that is, becomes problematic down the line. And make sure that your bedroom is dark, quiet, and cool. People who have trouble falling asleep, sometimes I tell them take a warm shower as a contrast, and then go into your bedroom, make sure it's dark, it's quiet, and it's cold. Well, cool enough, like comfortable enough, not like when you're shivering or freezing. Why? Because in order to fall asleep, your core body temperature needs to drop. You don't fall asleep if the core body temperature does not drop. So that is why it's important to keep the bedroom cool. And obviously, any kind of noise, you want to minimize. If somebody else living in the house, make sure that they respect your sleep time. All right, so that's basically it. I want everybody to sleep well and be well. And if you guys have any questions for me, now is the time.
Thank you, Dr. Martis. I'm gonna get it.
There you go.
Martirosyan. Thank you so much.
You did it. You're welcome.
There were a number of questions that were sent in during registration by people who aren't even here, but I'm going to ask them anyway. And I want to know, if you're here and you have questions, either use the chat if you're shy, or open up your mic and go ahead and ask your question. But I'll kick off the questions with one that was received during registration. You talked a lot about obstructive sleep apnea. Can sleep apnea be reversed? Can it be reversed?
So good question. So it depends on severity, right? There are certain factors that can be reversed. If the patient has mild sleep apnea and is obese, by losing weight, you can reverse obstructive sleep apnea. Absolutely, yes. However, I promise the severity will definitely go down even if you have more severe sleep apnea by losing weight. But I can't promise that, it will eliminate all sleep apnea. But yeah, it can be reversed. But most of the time, the treatment, if the patient is not overweight and have sleep apnea due to anatomical structure, then most of the time they just need treatment. It will not get worse unless the anatomical part is corrected. Like recessed jaw, let's say, some people may go into surgery and break jaw and kind of make it forward to make more space, but that's a bit brutal to me. I think there are non-invasive ways of treating sleep apnea, yes.
Okay. The next question, does a CPAP really help? And can you explain what a CPAP is and how it works?
Absolutely. Yes, absolutely. Yes, CPAP, it stands for continuous positive pressure. So what it is, it's basically, if I was in my lab, I would have showed you. It's an electronic device that sits on your night table. And it connects with a hose to a mask that can fit either under your nose, over the nose, or over nose and mouth, however you prefer. The mask does not change the therapy. And what it does, it senses when the airway is closing and it's stopping breathing, it pushes a puff of air, okay? That's opening out, serving it as a stent, opening up your collapsed airway. Okay, so it kind of pushes air in whenever you stop breathing, okay, to maintain normal respiration.
Thank you. Anyone else on the line have a question?
Yes, I do.
Yes, yeah.
No, this is Faith Drummond. I had a question about two, really. One about napping. I know this past week, clearly I'm not getting enough sleep, was dozing off at the stop sign in the car.
Oh boy. That's
And,
dangerous.
and I just kind of prayed and got myself home. But that's something that just happened I noticed this week. So that's why I'm very tuned into this. So the question is, in taking, and I understand what you said about getting a regular pattern, and I'm working, but can you, but it naps in the afternoon. Is that a bad thing to do if they're short and not late?
No, so there is no problem really napping in the afternoon if your schedule allows. The only problem sometimes arises is that people who may nap like later on may have difficulty falling asleep, because think about it, we are given a certain amount of sleep, let's say 8 hours of sleep per 24-hour day, right? So if you slept for, let's say, an hour or half an hour before, you may have trouble, your sleep drive kind of decreased because you took a nap. So your sleep drive, what comes at night, is not strong enough for you to fall asleep. So you might find it difficult to fall asleep. That's why I usually discourage taking naps, because they can lead to initiation insomnia, like difficulty falling asleep. But did you notice that it troubles you when you go to bed to fall asleep if you've taken a nap before?
If I do it, sometimes if I'm very tired and I do that, then it causes me to go to sleep even later because I'm just sleepy. So that I understand that, and I just have one. Well, I have a lot, but I'm going to ask one more. I wear a dental. What do you call it?
Dental procedure?
Yeah, for the teeth, at night, the brace, the what do we call those appliances?
Correct. It's called mandibular advancement device. Yes.
Yeah. How does that affect? Because I've always, my dentist, I would just say, she said, "Are you wearing it? Are you wearing it?" I always feel sometimes I'll wake up and I have actually taken that thing out of my mouth, and I'm just wondering, is that affecting, the breathing at night?
Yes, so mandibular advancement devices are very helpful in patients who have mild disease, mild obstructive sleep apnea. Maybe in some cases moderate, but mostly mild, okay? It does not work very well in severe sleep apnea, right? So it depends on the severity of sleep apnea, the modality of treatment that we choose, right? So yes, in mild cases it works, and it usually you will feel it because it doesn't, unlike CPAP, it does not give a physician feedback how well you control the disease. So the physician has to rely on the patient's symptoms. So if you tell me when you sleep with that thing on, you're sleeping well, you're no longer feeling sleepy during the day, then I'll say, oh, great, well, it works then. I have no objective way of seeing it works, okay?
Okay, yeah.
However, with CPAP,
No, this is the dental appliance that the dentist for TMJ.
For TMJ that did it. Okay.
Yeah.
So that is different. So we are not talking about specific mandibular advancement device that is meant for sleep apnea. These are different. It may not affect your sleep apnea or help it at all if you have it.
Okay.
You definitely need to be evaluated, because the way for sleep apnea apparatus, so it's kind of two things, like fits on the top and the bottom teeth. And it protrudes. The way it works is like they slowly crank up the sides, so it becomes shorter the sides and moves this lower jaw forwards, that's opening up space in the back. So the whole point is to open up space in the back so you don't obstruct for sleep apnea. I'm not talking, but if you have TMJ, that's a contraindication. That's not a treatment, because it may worsen your TMJ.
Okay.
Are there any other questions in the group?
I had one. I saw a commercial, and I didn't pay very good attention, but it was an alternative to a CPAP machine.
Right.
Because those seem so intrusive. Do you know, is that just kind of a gimmick, or are there other devices?
No, it's not a gimmick. If you're talking about, I think you're talking about Inspire. Is it something that you have a remote control, right?
Yes.
Yeah.
Yes.
So first of all, talking about intrusive, you understand it's a surgery. They implant metal in your chest
Oh,
that
wow.
has leads that go down inside your
Oh.
body, go up to the base of your tongue.
Oh
They
my.
don't say that on the commercial.
No, they
Yeah,
don't
of
say
course they
that.
don't. Yeah, and it senses when you stop breathing, and it kind of like shocks the tongue to protrude it forward, so it's not back. So tongue
Whoa.
comes out of the front teeth, and that's how it solves the sleep apnea. I'm not saying it's not recommended treatment. It's definitely not the gold standard, but for people who can't tolerate CPAP at all, who really tried, this might be an option. Yeah, it can be pricey too, if it's a surgery.
Right.
But yeah, I've seen patients with that. Yeah,
Okay.
and it's not for everybody. You have to have a low body mass index, less than 32.
Mhm.
Yeah,
Wow, that's a
but
lot.
yeah,
Thank you.
it's definitely an option.
So
that
Dr.
definitely-
Martirosyan, I can see,
Yes,
I can say it really, I can say your name now.
yes.
There are a few more
Uh-huh.
questions here from folks who registered.
Uh-huh.
What is narcolepsy, and is that
I'm
related?
sorry, you're breaking up. Can you repeat that, please?
Sure. What is narcolepsy, and how is it related to, or is it related to sleep apnea?
Okay, so yeah, so let's define narcolepsy first, right? Narcolepsy is a neurologic disorder that basically manifests as interrupted, it's dysregulation, chemical dysregulation in the brain that basically regulates sleep and wake. So we have intrusions of sleep during wakefulness, like and it manifests by inability to stay awake, like during the daytime, like people would just fall asleep during dinner, fall asleep at work. They just cannot sustain wakefulness. It's not their fault, it just happens, okay? And contrary to the common belief, they sleep normal amount of time like you and I sleep, but their sleep is very fragmented. So during the night when they're supposedly sleeping, the wakefulness comes in too, kind of barging in through the night. That's disturbing the sleep. So they have very fragmented sleep. That's causing extra sleepiness during the day, and they have this basically irresistible urge to sleep, to take a nap, and they feel very good after like a short nap, 10-15 minutes nap. They feel like they've slept for good night. They feel very refreshed after that. As whether it's related to obstructive sleep apnea, it's not related, but it can coexist with obstructive sleep apnea.
And so if their sleep is fragmented that way, are they still at risk for those same kinds of heart disease, stroke?
Yes, there
whatever?
is more risk of heart disease, yes, and hypertension runs with also exactly with narcolepsy as well. So narcolepsy by itself is a diagnosis of exclusion. So you have to treat the sleep apnea if there is sleep apnea present, right? If there's sleep apnea, you cannot diagnose a patient with narcolepsy. You have to first treat the sleep apnea. If they still have the same amount of this excessive daytime sleepiness or falling asleep, during the day, irresistible attacks of sleep, then patient has both. Then you treat the underlying sleep apnea, and you have to treat the narcolepsy with medications.
Got it.
Mm-hmm.
Any other questions?
Hi, this is Minnie Murphy. I have a quick question. Actually, I have two. As you know, many of us in the study have hypertension.
Mm-hmm.
And I am one of them. I'm also over 50. And so I have two of those factors.
Yes.
But my hypertension medicine is a diuretic.
Correct.
Which means that I'm frequently up at night diuretic. I never sleep more than 6. I'm lucky if I ever sleep 7 hours. I don't feel daytime disruptions.
Mm-hmm.
But I do have high blood pressure and I'm over 50. And so there are not many options there because I have to take the med, right?
Yes,
I know
absolutely.
Take it earlier in the day and I do that. But
Yes.
I also drink a lot of water because I think that's good for the health. And so I'm wondering if you have any opinions on what might be a solution. And secondly, how do you feel about melatonin as a possible remedy.
Of course. I'm glad you asked those questions, Ms. Murphy. So number one, yes, of course, you're taking diuretic, and taking it early in the morning is preferable. So it kind of runs out by the time to sleep. It also kind of important not to drink fluids after 6 p.m. Okay, because then obviously if you drink fluids after 6 p.m., you will fall asleep. You will urinate more at night, right? But that being said, also it's important to know, the diuretic is being diuretic, fine, but you need to know that whether you have sleep apnea or not, because diuretic might still make you urinate, but most people who have sleep apnea urinate more frequently because they're don't go into deep night sleep and they're more aware of their bodily function. So your bladder may be 25% full, yet because of sleep apnea, you're kind of sub-aroused. Your brain is not in deep sleep, and you're like, oh, I have to go empty my bladder because there's some urine in there. While if your sleep apnea is not there, then you will be in a deeper sleep, and you may ignore that, feeling of bladder being partially filled until it's more full filled, when you wake up in the morning to empty your bladder. So that's when we feel like, even with people with diuretics, when they're screened for sleep apnea, and if they have it and they're treated, they notice, I don't know, 3-4 times they go to the restroom once or twice. Okay, much less frequently. So that's I think was your second question. The fact that you don't have any symptoms, I'm very happy for you. But remember how I said, if 50% of people will not have symptoms, that does not mean that they don't have the disease. If you have hypertension, you should be evaluated. Okay, that's another thing. Now the third questions I believe was because of the melatonin. So melatonin I recommend only for certain conditions, like circadian dysfunctions, when people like either go to bed too early or too late, or if they have trouble falling asleep. It will not help you stay asleep. Believe me, it will not. So it's kind of waste of money, and maybe we don't know the downside of taking chronically melatonin. If it does, I don't think it will help you to kind of stay awake and not get interrupted. As for you, so you think you're lucky if you get 7 hours of sleep. Is it because of the sleep fragmentation that you wake up to restroom so frequently that you get less sleep?
Yes. Can you hear me?
So,
Yes.
So that's why I'm saying it's very important for you to be evaluated, because if you believe me, you'll have the sleep apnea. If you don't have it, then just have to minimize how much liquid you take.
Okay. Thank you very much. That helped a lot.
You will see the noticeable difference.
Yeah, I had a practice of limiting liquids till 9 p.m. I'll roll it back to 6 p.m. and see how that works. Thank you very much.
Oh, well, it depends, a bit too late, unless you go to bed like 2 a.m., depending what time you go to bed. But yeah, 9 a.m. might be a bit too late to stop liquids. What time do you usually go to bed?
Midnight, 1. But
Okay, so yeah, try to limit it to not drink it after 8 p.m. then.
Okay, thank you very much.
Sure.
Great. Any other questions? There's still a couple here that I need to ask,
Sure.
but if you're here and you have a question, please jump in. Okay, one question that was received is it possible to catch up on sleep?
Okay, so yes, it's possible to catch up on sleep if it's, let's say, one-time encounter. Let's say I have an exam tomorrow, I pull an all-nighter, and next day I'm going to spend in bed all day. Yes, but chronically, no. So people who chronically undersleep during the week and say like, oh, but on the weekend I sleep 10 hours, that's not catching up. It's not going to equate to the same thing. No.
Okay. Here's a really good one. Can I really improve my blood pressure? I guess meaning lower my blood pressure by increasing my sleep.
By what? By, I'm sorry,
Increasing my sleep.
Okay, so good question. Also depends, how much your sleep is compromised, right? I don't think you will improve your blood pressure for sure by increasing your sleep to adequate amount, which is more than 7 hours, right? But it's also the quality of sleep. That's why you need to make sure that there is no underlying condition disturbing your sleep. So the quality is also preserved, not only the quantity. With treatment of obstructive sleep apnea, blood pressure does drop. It drops not as much as with medications. It's a modest decrease in systolic blood pressure. However, in patients with resistant hypertension, and by resistant we mean the hypertension that requires more than 3 agents to treat, 3 medications to treat it, the decrease is actually is much stronger. And they have much higher association of having sleep apnea if they have resistant hypertension compared to people with just regular hypertension.
Great. Okay. Minnie asked about melatonin. This question asks, what do you think about products like ZzzQuil?
Nah, I discourage them. You don't know what they put in them. They have a habit forming, they're disturbing sleep. They just zonk you out, and then I don't recommend it for insomnia. I evaluate what's causing the problem. So don't just put a Band-Aid on, right? Like, you want to treat the disease, the underlying cause. So maybe once in a blue moon you take it, fine, there's no problem, but taking it on regular basis, I discourage. Including melatonin is very mild. It's a natural product if they don't put like other stuff in it. But it's also at much higher doses sold over the counter than the natural product we made by our brain. So I only recommend it in like certain sleep disorders, as I said, circadian rhythm dysregulations, and also I can try it as initially for people who have trouble falling asleep, but that has to go hand in hand with proper cognitive behavioral therapy and having very good sleep hygiene and sleep routine. It can't be just like, okay, take a pill and you'll go to bed. There's no magic wand that will put you to sleep.
Mary Anders, thank you, Mary. I think she's busy and can't really talk, so she put a question into the chat. She says she has.
Yes, actually, I'm done now.
Oh, you're done?
I just came
Okay,
from the
good.
cardiologist, so I'm back. Sorry, thank you.
Sure. Okay.
You want to
very
ask
good
a question,
question.
Mary?
Yeah.
Pardon?
Mary's question is, she has both obstructive and central sleep apnea. What's the difference? And can either be cured?
Big difference. Yes, there's a big difference. So obstructive sleep apnea is what I just explained. It's the obstruction of the airway, right? So by tissue. Central sleep apnea, it comes from the brain, hence central. So it's when the basically the brain is not telling the body to breathe, giving it a pauses, right? It's also common with heart failure. In people who have heart failure, central sleep apnea, we see frequently is chain stop respiration. I'm not sure if Mary has heart failure. Another condition that can cause central sleep apnea is being on pain medications, opioid pain medications. That's another thing that causes central sleep apnea by affecting respiratory drive in the base of the brain. Causing the respiratory pauses, central respiratory pauses, not related to the physical obstruction of the airway.
Is heart failure? I have, in fact, I was in the cardiologist's office during this thing, which is why I had to hop off. I don't know that you'd say I don't have heart failure, but I have coronary artery disease and I have AFib. Does that contribute to central? Does that
AFib can contribute to central. central sometimes, but not so much. So centrals can be idiopathic. Idiopathic means like on its own. So if you're not on any opioid medications, do you have headaches, frequent headaches?
Yeah, I do.
Do you have neck pain?
Neck pain, no, mostly headaches, and I'm saying what's really helped for the headaches is actually been vitamin B2 and
Mhm.
magnesium. So because I
Magnesium,
didn't want to take any more drugs, and
yeah.
so
Yeah.
and caffeine when I have to. I'm trying not to drink caffeine, but because of the
Yeah.
heart, but sometimes it's the only thing that
Yeah.
gets rid of the headache.
That's right.
So headaches are connected. They're connected to central
Headaches,
sleep apnea. Oh.
sometimes, yes. So sometimes there is a we call it a Chiari malformation. There is a condition that affects that of the brain that herniates slightly to the lower part of the brain, causing pressure and headaches sometimes, and causing central apnea. So if I don't have any other kind of reasons to see why patient has central apnea, if the heart failure is not there, opioids are not there, no neurological deficits are not there, then I may send the patient for an MRI to make sure that the neck and the base of the brain is not causing the central sleep apnea. And if that's ruled out, then I just treat it. Then I call it idiopathic.
So how would you treat it? Just with this? Because I use a BiPAP machine. That's it.
Yeah, with the BiPAP, exactly.
Okay. So where should I mention this? Should I mention this to the neurologist who's treating my headaches, or the neurologist that I see for the sleep machine? Which when a follow-up, because they're two different. You're the first one who's ever made the connection.
Either one of them will do it. Either one of them can do it. Your sleep does, just say, well, you don't think I need an MRI because I have central sleep apnea, and then maybe they will tell you a cause that you didn't think about it, but they know the cause. But yeah, you could ask, did you have any trauma to the head?
No.
Did you ever have no?
And
again, that being very rare, I must tell you. So probably the reason they did not order it, it's because it's a rare condition. It's very rare. Okay, the Chiari malformation. Not the central. I'm saying the cause for the central. So most of the time it's those common conditions that I said, that like it's heart failure, it's opioids, but and also people who live in higher altitudes, which does not apply to us. But yeah, that's basically it. Other than that, it's rare, but it's possible. So I usually check. Being in an academic center, I just order it and check it to make sure I'm not missing anything.
Thank you so much.
You're welcome.
Sure. Thank you, Mary, too, for those good questions at the very end. Thanks to everybody for your questions, and thanks for coming to the very final lunch and learn for this cohort. And we want to thank Dr. Martirosyan.
Sure, it's my pleasure.
Say it for us, please. I know I'm saying it wrong.
Don't worry about it.
Can you say it for us, please? Say your last name.
Sure, it's Martirosyan.
Martirosyan. I had it right one time.
Yeah, you did it.
So thank you, everybody, and thank you, Dr. Martirosyan.
All right, guys, don't compromise sleep, okay? Very important.
Yes, thank you so much.
This was
final words. Yes.
Thank you. This was awesome. Thank you.
Great.
Okay.
Sure.
Okay.
Bye-bye.
Okay. Bye-bye.